Good evening. I think my camera's on and I think we're on stage. I'm waiting for Dr. Giles to join us. Hi there, Dr. Giles.
Hello. Hi, thanks for having me.
Can you hear me okay? We can't hear you.
Yeah, I can hear you. It
You
says
gotta
that
you gotta turn on your
it's on.
microphone.
Is your volume on? Okay, somebody, Anthony.
Let me see. Yeah, hi everybody. Thank you for joining us on this webinar. Give us a couple of minutes. We're gonna be fixing our some uh, issues. Hold on one second. All right. I think we're set to go. Um, Hi, everybody. My name is Paige Pejman Badi. I am one of the owners of the Sanctuary Dispensaries in Nevada. I'm also a physician. I'm a board certified family practice emergency medicine physician that I'm currently working on cannabis as well as pain management and etc. And we have the honor of having Dr. Julia Giles join us today as our guest to enrich our brains with all the information that she's gathered throughout the years with her impressive history. So, Dr. Giles, welcome.
Thanks so much. Glad to be here.
Thank you, thank you, thank you. Good, good, good. So, where are you calling in from, Dr. Giles?
I live in Seattle, Washington. That is where I practice medicine. I'm licensed in the state of Washington as a naturopathic physician and practice medicine kind of south of the university district, north of, or on East Lake, basically.
Awesome, awesome, awesome. And so what is it? What is? I know what naturopathic medicine means, but I mean, naturopathic medicine is such a huge, broad vernacular nomenclature for so many things. So can you just let us know what that means, and within that spectrum, where you fall in, and a little more about yourself and educational background, and kind of who you are, and uh, uh, and who we have as a guest, so our listeners and myself understand a little better.
Yeah, absolutely. I can start. I think the best place to start is with education. So, I got my undergrad at University of Wisconsin Madison. I'm originally from the Midwest, and while I was there, I originally thought I would study languages, and instead, life led me to medicine. I studied pre med there as well as actually Sanskrit and other sort of South and Southeast Asian studies. Um, but while there, that was where I really began studying cannabis, especially in the context of cancer. So I've always had an interest in cancer. My grandmother got cancer when I was pretty young, and and I've always, or not always, but for a long time, been interested in natural medicine. So while I was in school, I essentially decided I wanted to pursue a doctorate in some sort of natural medicine or some sort of holistic, sort of integrative medicine. And that is how, through some research, long story short, I found Bastyr University, which is in Kenmore, right outside of Seattle, Washington. So from there, I went pretty much straight from undergrad into grad school, and there I did a dual track in naturopathic medicine and Ayurvedic medicine. I've been studying Ayurvedic medicine personally for many years, originally through my studies in yoga. I'm a long-term yoga practitioner. So I did this dual track master's and doctorate. And how I can describe naturopathic medicine, essentially it's really just holistic medicine. I guess the difference between that and other, conventional medicine, allopathic medicine, or even osteopathic, is that we follow a therapeutic order. That means, actually, that's behind me, or there's something behind me, but the therapeutic order, meaning we use low force interventions first, things that are going to have less negative effects or side effects on the body. That can be diet, just making dietary changes, changing lifestyle factors, including exercise, and looking at the person in a holistic manner. We have different principles, tenets, etc. But essentially, we're looking at the whole person, we're treating the whole person, and we're trying to do the least amount of damage while supporting the system. I guess it resonated with me, and the reason I wanted to go to school at Bastyr was because of that holistic approach, but it's also very evidence-based for the most part, or can be, depending on who's practicing. As you said, it's very broad, but for the most part, I also really love science. I did a lot of scientific studies in undergrad, and I wanted to make sure that I wasn't just throwing darts, or, I love the practice of traditional medicine, like Ayurveda, but I wanted a really strong scientific background as well. And I wanted to be licensed as a physician, where I can actually practice medicine and be a physician. So that's what led me there. After that, I did residency at Ames Institute in Seattle. It's a private practice. And I started specializing more. I guess I also should mention in medical school, I furthered my education, my personal education on cannabis as a medicine. And was very surprised and somewhat disheartened to find that there was very little discussion of it, even at my school, which is one of the top schools in natural medicine in the country. There just was very little discussion of it. They didn't really want to touch it too much. So I did a lot of self-edification, wrote papers, did research, etc. Then when I went to residency, I did a 2-year residency specializing primarily in oncology, integrative oncology, naturopathic oncology, and started furthering really specializing in cannabinoids as far as like different types of cancer, not just is cannabis helpful for cancer, but what kind of cannabis and in what way and what type of cancer, and really honing in on that, as well as many other things, including psychedelic assisted psychotherapy. We use ketamine. It's the only thing that's legal at this point, at least for outside of research settings. And did a lot of other stuff, a lot of work with chronic pain, hormones, metabolic issues, neurological issues. I would say those are the main things, but it was a pretty wide demographic and a lot of different stuff. I got exposed to a lot of various things. So once I finished residency, I am now still practicing at Ames as an attending. There are a lot of new residents, which is exciting. And I'm just really further honing in on those skills, and also started cannabis-wise, started teaching more about cannabis in about 2 years ago through the Academy of Cannabis Science with Trey Reckling. So I co-teach certain courses with him, and have also done quite a bit of work in herbal formulations, generally formulating cannabis with other herbs to make full formulations, basically for different effects, different kind of magnifying or enhancing the widely varying effects of cannabis. And so, yeah, a couple of different companies with that, because I love herbal formulations as well, and really, again, enhancing the endocannabinoid system in various ways. And I still also am a ketamine-assisted psychotherapist. Technically, I'm not a psychotherapist, but I do ketamine-assisted therapy, psychotherapy, which is also very diverse in its applications.
It's impressive. It's funny when you say traditional medicine, Ayurvedic medicine. For you, traditional. And for us, I'm a emergency guy. We cut people open and do that whole thing. So when you say traditional medicine, I think Western medicine, and then for you, traditional medicine is Ayurvedic medicine. And just like I love the juxtaposition of the definitions of medicine for a naturopath. And by the way, I'm an osteopathic doctor, but I went to the allopathic route, kind of a thing. But I love it, and I think and I come from a family of allopathic doctors. My brother's an MD, my dad's an MD, and all that. And it's really interesting that you look across the board and the thought process of one end of the spectrum, which is the allopathic doctors, and then I think the DOs are a little bit more towards the center, and then naturopathic physicians that are on the other end of the spectrum, and just how their brains work is really interesting for me. And like you, I got into my mother had cancer, and she finally passed, but she stayed alive for 7.5 years. And I started giving her cannabis, and that's how she stayed alive. And at the beginning, my dad, who's now 85 years old, still practicing medicine 5 days a week, and my brother, and when they would sit there at the dinner table, they're like, you're giving drugs to my wife. You're making my wife a drug addict, and they were completely opposed to this concept. And then once they saw how she went through chemo the first time around without cannabis, and the second time around with cannabis, they're like, they shut up actually. But I mean, when they said nothing, that meant that they approved of it, But their thought process of an allopathic physician versus a naturopathic physician. So it's thank you for walking us through your history, your amazing history and education. And by the way, let's take a second. Whoever's on listening to us, if you have any questions, please interrupt via your text. We'll try to get into it at the right time, so you don't have to wait till the end of the webinar. I really want this webinar to be soft and gentle and flowing and loving, as opposed to a very rigid discussion. And on top of that, the meat of this webinar is around psilocybin or mushrooms and dosing and microdosing, and because it's becoming such a huge thing, and I feel like it's following the path of cannabis. Dr. Giles, if I get sidetracked, which I usually do, please bring it back to the center. But that should be our focus. But I'm really interested, before we get to the psilocybis, treatments, diagnoses, and so forth. I want to focus a little bit about cannabis, and it's very interesting to me that you have educated yourself in the cancer diagnoses that would respond in a particular way to the particular type of cannabis. Can you expand on that a little bit? Because I've been in the cannabis world for 8-9 years now, and I teach in the endocannabinoid system and so forth. But I really want to hear this.
Yeah, absolutely. So this has been a long process of, like you said, I mean, like we both said, self-education, because I would see a new type of cancer. When I was a first year resident, it was like, okay, I'm seeing an ovarian cancer patient. What am I going to, they want to know about cannabis. What am I going to tell them? Like, I don't know. It probably helps. Like, no, I have to go to the research and figure out what have we found helps. And it can be challenging, and it can take a long time to extrapolate from studies into a human body. But I always have to take in factors, like we can look at breast or ovarian cancer. I guess breast cancer is probably easier in the fact that estrogen receptor positive breast cancer is going to respond differently to various cannabinoids than something like triple negative breast cancer that has estrogen and progesterone receptor negative status, and HER2 negative. But regardless, that they're going to behave differently. You can utilize more THC in somebody who has estrogen receptor positive breast cancer than negative because of the way THC modulates the estrogen receptor. So the dosing, or not necessarily the dosing, but the ratio of cannabinoids is actually different. Also, with different cancer types, there are different effective doses. So sometimes the dose is actually, like with glioblastoma multiforme, which is the most aggressive form of brain cancer. I would say the two types of cancer that I've specialized in the most. I mean, breast cancer is the most common I see, so that's a given. But glioblastoma and pancreatic cancer, those are the cancer types that I like to work with the most, and I think respond best. I've seen respond best to integrative and naturopathic therapies, and they also have probably the worst conventional options available, so it works out well. But glioblastoma, all of the research shows really low amounts of cannabinoids are helpful, but it has to be in a it doesn't have to be, but it should be in a 1-to-1 ratio. And then just recently, just in the last year, they've found that CBG is probably just as effective, if not more effective than CBD and THC. So now it's like maybe a 1-to-1 is probably ideal. So it's growing all the time. And so 1-to-1 meaning CBD, CBG, THC. So in that ratio, and then the lowest, I believe, I would have to look at in my resources, but I believe that it's something like 25 milligrams is what has been researched for glioblastoma of all cannabinoids. So like 12.5 each of CBD and THC. That's tiny. That's super small. Often we're giving 50 to 100 milligrams at least twice daily. So it's quite interesting. And then cannabinoids are pretty much a must in my book with glioblastoma because it responds so well. And I've seen in human beings how much it prolongs survival and quality and quantity of life. Just almost miraculous turnarounds when I've gotten certain patients who were totally decompensated on high dose cannabinoids. So certain types of cancer are going to respond more robustly. But it really is, just to say, here's an authorization, smoke some THC for your nausea. It's not doing a great service to a patient. I mean, quality of life, sure, but we can do way better. And there is a ton of research. I hear that a lot. Well, we just don't know. We don't, but we know a lot, and it's growing all the time. There's tons of research happening in cannabinoids, and it's really exciting. But it's a moving target, like I said, with the glioblastoma. It was like, okay, always do 1-to-1, but now they're like, wait, CBG is probably even better. So that is uprooted. So it's also the responsibility, I feel, of the physician to keep up with it and to keep looking and to keep making sure, is this still accurate, or have we learned more about this? Because it really is important to realize that the principles of cancer are all the same, but it really is, each type of cancer is completely different. And also in the person, mutation types, mutational burden, like it's so diverse, even with the same type of cancer. Like breast cancer, to me, just saying that it means very little because there's so many subtypes there.
Small world, I think, but I was a speaker with Trey as well, and we had a really, really good meeting at that one time. And I brought this up at that time, but and it's funny you bring up glioblastoma. One of the best researchers, and I was a laboratory rat. And just like in the movies, like I was in a basement at the university, and I worked with Dr. Oppenheimer actually, which is a famous guy. I love looking at research, but one of the best research I found, which was done about 7 years ago, a Spanish study about glioblastoma. I don't know if you heard about it. It is by far the best study I've ever seen in not only in cannabis, but almost in any other drug agency, single level study that shows that the actual not only cessation, but reduction and curative level of glioblastoma in mice with THC.
Mhm.
I don't think they're specific enough back 7, 8 years ago to talk about the CBD THC level. They're just, oh, we gave them cannabis, But I 100% agree with you. If I was going to do a study right now, neovascular my mice, it would be CBG and CBN. Excuse me, I get excited. But CBG has a huge effect on the C2 receptor on the endocannabinoid system. So I would assume that would be the portion of the endocannabinoid portion of it with the entourage effect of THC. So I don't know. Do you know about that study I'm talking about? Have you heard of it?
Yes, definitely.
It's just a game changer.
Mm-hmm.
So
Mm-hmm.
yeah, so I agree with you 100% on the glio, and maybe that's probably the real knowledge I have relative to your vast knowledge about all the other stuff. But is there anything about breast or ovarian that you would know that any combination that you would recommend?
Yeah, absolutely. I would say I'll keep it as simple as, is it estrogen receptor positive or negative? If it's ER positive, then generally I would recommend probably about a 5-to-1 ratio of CBD to THC, and generally 50 milligrams twice daily orally. And for ER negative, you have to be more careful and have less THC. So no, I would say 10-to-1 or 20-to-1 to 10-to-1 CBD to THC. Again, probably same dosage, at least probably 50 milligrams twice a day. Triple negative is a tough one, so I would probably up it a bit. But the research, at least when I was doing, this is a good example of, I should probably go back and see what about the other cannabinoids, but CBG was still pretty well studied at that point for breast cancer, and it wasn't coming up. But CBG is something that has come up in my research for ovarian cancer. So ovarian cancer is pretty much 100% ER positive, and so the same rule would apply. Maybe 5-to-1 to 10-to-1, or 10-to-1 to 5-to-1, but also adding CBG. And generally, I do a 2-to-1 CBD to CBG ratio. So the math gets a little bit less clean there. I mean, we could say probably like 10 to 5-to-1 would be reasonable, of CBD, CBG, THC for that. So it's also interesting that even though they're both ER positive, there just isn't as much evidence about the effectiveness of CBG for breast cancer. Not that I think it hurts anything by any means. I mean, I love CBG and think it is like great for a lot of reasons. But there just wasn't, and again, at least at the time when I was doing a ton of research on breast cancer in particular, it wasn't found to be as effective as it was in ovarian cancer. So go figure.
Is there just for our viewers, listeners, whatever? I don't know what you call these things on the webinars, but is there a library or a book or anywhere that has a set of not curative but therapeutic responses of which combinations of the endocannabinoids and matched with a diagnosis? Do you know where this stuff can be found?
Not as much. There isn't as robust of information for types of cancer, other than my favorite resource for people, for just that anybody can get, is the Cannabis Pharmacy. And the Cannabis Pharmacy does have, I wouldn't say as many cancer types as there are, obviously. I mean, I've seen some very rare types of cancer, but at least for things like breast cancer, ovarian cancer, prostate cancer, things like that, it's going to have the basics, and it has some pretty incredibly specific recommendations for a lot of things, like MS, multiple sclerosis, and all sorts of, like, if you just look up a condition, there's a lot of good information. I will say that it's probably somewhat outdated, even though it's not that old, just because cannabis research is happening so rapidly. But I think they're updating it. So I'd say that's probably what I generally recommend is the best medical cannabis resource outside of, Honestly, mostly I'm just doing PubMed research and sitting and writing out massive bibliographies and all the data that I can extract to make it clinically applicable.
That sounds great. I would love on a selfish, super selfish, private note. We have dispensaries. We're actually doing. We manage pain management centers, and we're getting a study up and running. It's a large study, 300 cohort study. Sorry, and to replace opiates with cannabis, with a colloid material which is called Bestasorb to increase absorption, and we're working on the formulation of it, and I would love to be able to expand on that, not for pain management, but other treatments like nausea, treatments for palliative treatments for patients who are on chemo with a huge amount of CBN, and to increase their appetite and so forth with the colloid, that sort of thing. So I might hit you up on the side to tap in your brain when it comes time for us to make additional medical formulations. We're very medically friendly dispensary, so for now, let's dive into. I have a whole bunch of other stuff, including what kind of cannabis we use and the quality of cannabis, and the other treatments and ailments with how would we change the quality of the cannabis we're going to be using, that sort of thing. But I would like to stop cannabis first because I'm sure you and I can go at it for hours.
Yeah.
It's 6:27. We have another 33 minutes. So let's walk into the psychedelics, and I think ketamine. You brought out ketamine up, which is very interesting. We do ketamine treatments in our pain centers, but can we? So I would like to talk about ketamine, but before we get there, on the psychedelic side, I think right now there's a lot of hype about psilocybin and treatments and microdosing and so forth, and I think it's a great topic with someone. We get to have you for another 32 minutes. So if whatever you can let us know on what your understanding of this medicine is, how it affects you, and what your recommendations are. Who is it good for? Who is it not good for? What are the treatment choices and that sort of thing, please?
Yeah, of course. And I think it's a good segue also, because that was another alongside studying it when I was an undergrad, alongside studying cannabis. That's when I got very into medicinal mushrooms, and did a lot of research on medicinal mushrooms, again, at that point, looking at them for cancer. And so really, that's actually how I ended up finding it. One of the reasons I wanted to go to Bastyr, and how I found who ended up being my mentor and attending physician when I was in residency, was through her, because she did the first human trial on medicinal mushrooms for breast cancer, actually. So bringing it full circle. But so, mycomedicines or mycological medicines, mushrooms, in the fungal kingdom, I think are some of the most potent medicines on the planet, absolutely. And they're underrated. They've gained more, as we're saying now, they've gained more popularity over time. I used to have to say, medicinal mushrooms, not like the psychedelic ones, but as it turns out, psychedelic mushrooms are also very medicinal. So specific to psilocybin, I guess the thing yes.
When I apologize because I don't want to the rest of the talk go with, but before you define for us potent.
Yes.
What do you mean by potent? Potent could mean, has a lot of meaning. I just want to make sure we're clear in our heads before you go any.
Yes, absolutely. So
Sorry.
for me, no, it's good. It's good. Potent, I guess, means powerful to me. Potent is just like powerful, especially if we're talking about psilocybin. Like a tiny, tiny, tiny bit goes a long way. You don't need much to have a therapeutic effect. So I guess that's how I'm defining potent. So yeah, little going a long way. I mean, like if we're talking about microdosing, technically, even though there's no real, the general consensus is 0.2 to 0.5 grams of mushrooms. So tiny, tiny amounts is a microdose. Beyond that, somebody has psychedelic effects. In that window, well, of course, this is highly individualized, right? So some people, 0.1 or 0.2, they're going to feel the effects cognitively. For other people, it might not be till 0.5. So that's why there's kind of a broad range. But generally speaking, in those lower amounts, somebody doesn't feel altered, inebriated, not having visual enhancement or auditory enhancement. Things are just, I always say they just burn a little brighter. Things tend to just move a little bit easier if it's a good fit, if this is a good fit. Of course, not every medicine is for every person. Not everybody's going to tolerate things. I think right off the bat, I can say, with all psychedelics, including psilocybin, the people that it's least indicated for and the people who should be the most cautious and tread the most lightly in general are anybody with a history of psychosis of any kind. So that can be schizophrenia or that whole spectrum of disorders, potentially, depending on the person, maybe bipolar, if they've had a psychotic episode in a manic episode, for example. I think Michael Pollan says it best that the research shows people who are too orderly in their mind, things like OCD, anxiety, depression, like there's too much rigidity, almost like a loss of neuroplasticity. People who are too rigid or uptight, neurotic, those are the people who are going to respond the best to psychedelic medicines versus somebody who's already too disorganized, too kind of out there, already too creative, having hallucinations, etc. They don't need more of that. They need more order. So thinking of it in those terms, and the reason being it can actually do harm in those situations. I mean, I've seen people with undiagnosed bipolar have massive manic episodes with psychosis due to ketamine, for example. Like I've witnessed it in office, and yeah, it's not. It'll definitely teach a person don't do that. But for most people, anxiety and depression, I would say, are the best researched, and and PTSD are the best researched as far as psilocybin. So yes, we can talk about microdosing. That's very beneficial, and I can loop back and go further into that. But then as you get farther up in dosing, like I said, there's a full psychedelic experience that lasts about 6 hours and is deeply therapeutic. The experience itself is deeply therapeutic and can have tremendous lasting benefits for somebody for weeks to months to even years, just one experience of these peak experiences, but it's not right for everybody. I think the other most important thing to say about it is that it's working on the serotonergic system, so serotonin receptors. That's where psilocybin hits, and psilocin. So that's why a trigger for mania for many people with bipolar is too much serotonin. So if you're messing with that, it can cause these adverse effects. But serotonin is well known to be beneficial, and serotonergic things are well known to be beneficial for depression, anxiety, OCD, PTSD, absolutely. So if there's also great benefit for a lot of physical conditions like IBS, fibromyalgia. The serotonergic system is highly implicated in those, I don't like to say diseases, syndromes. So basically, if somebody can benefit from activating, kind of like we say with the endocannabinoid system, somebody can benefit from activating the serotonergic system, they'll likely benefit from psilocybin. And that's really on the physician to know whether or not that would be indicated. Obviously an SSRI or like something like Prozac isn't going to be indicated for everybody. So it's kind of similar. I would say it's in that vein, but it works a little bit differently. It's gentler and more diverse in its actions, as all plant and fungal medicines are. It's not one molecular target like an SSRI that's working on one channel predominantly. There are a lot of different things happening. And I think the most exciting part about, for me at least, about psychedelic research, and definitely including psilocybin, is that neuroplastic component, that neuroplasticity component. And these substances are actually, there's a term, neuroplastogens, meaning they increase neuroplasticity of the brain so that people can be less rigid, more flexible, more creative, more open, and less fixed.
Thank you for the great explanation. I have a bunch of questions, but the neuroplasticity discussion he just had. Right now, people use neuroplasticity for learning disorders, or not even disorders, just people want to learn new information or new pathways in the brain, especially with memory. A lot of these studies that are coming out that memory is looking at stepwise progression of information coming in, so your brain can retain more of it. And with neuroplasticity, you'll be able to retain more and have more number of receptors open to learn. So does this neuroplasticity effect of the psilocybin increase your learning ability?
I would say yes. I mean, it depends on how something's utilized, but there's the molecule in question here is BDNF, which is brain-derived neurotrophic factor. And that molecule upregulates neurological pathways, that basically creating new pathways, actually creating new neuronal connections where it didn't used to exist. So absolutely. I mean, just with what you said, if you're branching off on these points and now all of a sudden one learning focus, the study of one thing has 10 different branching off points, obviously it's going to be way more solidified in the brain as far as retaining that information than if there's one. So, if there's only one and you don't think about that one thing, then it can just go away and you forget something. But when there's 10 things, it's that focus, that learning focus is going to be rooted in there. So you can actually, and so when I say it depends on intention and the way they're utilized, is if, and this is a big thing I do in psychedelic therapy, is, if somebody has this really massive peak experience in office or out in nature, whatever they're doing, but then they don't take that into their lives. They don't start applying what they learned to, in this case, I'm thinking of mental health concerns, trauma, etc., pain. If they're not applying it, it's going to be there. The brain is just rich with this BDNF. It's just just primed to make new pathways. But if you don't use it, you'll lose it, basically. And so that's a big part of, I think, everything. So being intentional about how somebody's utilizing something and then practicing it and putting it into action. So if somebody is struggling with depression, then, there has to be some sort of how are we going to, obviously, usually there's deeper layers, such as mostly trauma, PTSD, et cetera, certain things that can come up. So if we don't reacquaint ourselves with the things that we're ruminating on, if we're depressed, if we don't start to literally branch out and make different pathways and try to create a new relationship, then it's just going to be the same thing. You'll feel great for a little while, but it's going to be like taking any drug, any feel good drug. You feel good when you're on it and then it goes away and you don't. That's not, that, in my opinion and in my experience, that shouldn't be the intention with intentional psychedelics, is because you can actually utilize it to form those new relationships, to form those, to learn new things, form new relationships with pain, with physical pain, mental pain, all of it, or anxiety. And I've seen huge disruptions in all sorts of mental health conditions using psychedelic medicines. And once those new pathways are there, they have to, again, practice and kind of keep oiling those new pathways, using them. And then it's the new pathway, then it's just the way the brain works now. So you can actually sort of recirculate, you can use these medicines and the molecules that they're upregulating in the brain to really recircuit the brain in a way that we never knew was possible even 10 years ago, I would say.
That's amazing. Wow. Again, I really, I apologize to our listeners. I think you got two doctors on this talk. You know, it might get a little too technical, but I really have to ask. So I'll make it quick. So the effect on the dopamine receptors versus the serotonin receptors. I'm assuming there's some crossover to the dopamine receptor, especially when you change the dosing on microdosing versus not microdosing, or if you're going to start increasing from 0.2 milligrams to 0.5 or higher, does that increase your effect on your dopamine receptors, or the binding ability on the dopamine receptor?
In general, I would say it's going to depend on the psychedelic medicine. With psilocybin, it's less of a concern. But that being said, there are kind of two protocols with microdosing psilocybin that, well, I have a couple of other things to add to that protocol, but as far as frequency, what is utilized, it's usually 4 days on, 3 days off, or every other day. So, and including, so either way, it's 4 days a week. So either like Monday, Wednesday, Friday, Saturday, or, you know, however a person wants to do it. Everybody's a little different. Everybody kind of finds their groove with it, what works. But you do, essentially, the point is to have a washout period with microdosing to prevent that tolerance, you know, the dopamine receptors from being overactivated. You know, you don't want, psilocybin in general has, for the most part, anti-addictive properties. You know, it's not something that people, for the most part, like really get addicted to. And it actually has anti-addictive properties, because if somebody tried to eat, let's say, like an actual psychedelic dose of mushrooms multiple days in a row, they won't be able to trip. They won't be able to have those effects. So it just kind of makes people feel sick. And, but you're still trying to kind of prime those receptors and then wash them out, prime them, wash them out. It's not like something like an SSRI that people take every day continuously. Ketamine, I would say, definitely affects the dopamine receptor more than psilocybin does. And so there's definitely more of a potential for abuse and dependency and the euphoria. But even so, I would say that's actually kind of paradoxically, well, yeah, in high doses, way less so, because it's such an intense experience to have a high dose ketamine session versus microdosing. Microdosing is kind of a whole different ball game and can be very, very helpful for certain things. But I have experienced clinically that there's more, it's more dangerous waters. You know, you have to tread lightly with it. And that is really because of its action on the dopamine receptors, which is a lot more robust than with psilocybin. So yeah, to that point, yeah, euphoria, tolerance, et cetera, potential more, a greater potential for abuse with that one.
We do a high dose IV ketamine in our pain management centers for depressions, for post traumatic stress disorders, and so forth. And it's almost like a catatonic state when these patients go under when we dose them. So I agree with you there. But going back to the microdosing, so that diagnoses that you would recommend the patients to be on are anxiety, depression, post-traumatic stress disorder, OCD. And how about anything like MS or any of the neuroaffective disorders like cerebral palsy or seizures, and those are those candidates?
Seizures, it would depend. I would say it would be pretty highly dependent on what's causing the seizures, but everything else you said, yes. I think of psilocybin and psilocybin mushrooms in general as a neurological medicine. I mean, that's what they are. They're targeting the neurological system. So it can be very helpful for MS, various spastic disorders, although cannabis is kind of higher for me for spasticity, but still, so something like MS, and really any myriad of neurological disorders. I would say the same for ketamine. It's a neurological medicine. It really focuses on that nervous system. So anything that relates. The one thing I would say is it's going to be something like ADHD is going to be highly dependent. Some people with ADHD really respond well to psilocybin, to microdosing psilocybin. Other people not so much. It can cause actually more scatteredness for certain people. So that's going to be person dependent. But yeah, most, I mean, I'm trying to think of things that are not, I can't really think, most neurological issues will respond in some way to psilocybin.
Now, thank you. Yeah, that makes a lot of sense. Now, there's a question that's asked here about the strength and strains of mushrooms, and I actually had the same question. What is the best way to consume this, and is there a standard way to consume? Because I'm assuming, I know it's in your state it's legal, but in most states is so. Which states is it legal in anyway at this point? Do you know?
It's mostly not legal from what I understand in any states, but more so cities. So like the city of Seattle where I am, decriminalized plant-based and fungal-based medicines. And I know the Bay Area of, so San Francisco and Oakland, Denver they're all decriminalized. But I don't know that any states at this point have, Oregon passed psilocybin for for medical use, for supervised medical use. We assume, and there's actually petitions that a lot of physicians are signing in Washington for the same. So it's likely, I would say, in the next potentially few months, no more than 2 years, we'll have it. But that'll be medical use only, not rec at first, recreational. But mostly it's cities and urban areas. So we get questions all the time. Actually, my clinic is suing the DEA right now for right to try for two cancer patients who want to use psilocybin assisted therapy before they die of metastatic, stage 4 advanced cancer. And it got denied, I think, just last week, but they're repetitioning. And at some point, I assume that actually might not go through before Washington makes it legal for medical use. It'll be kind of a race, but at some point it'll be there. But at this point, I don't think any state other than Oregon has officially passed it.
So if anybody wants to microdose, then it will be they will be doing it essentially illegally.
Correct.
But again, I'm not, our discussion is not at all about what's legal, what's legal. I don't believe in half of the stuff that we do in our healthcare. It's the outcomes for the patients. That's what we're looking at. So to get the best outcome for the patient on a illegal drug, how would you obtain it, and how would you know it's the quality of it? And is it in oil? Is it in powder form? Is it? I know you said this every other day or 4 times a day. I'm assuming it's a QD. It's not a BI. I'm sorry. It's like a once a day. It's not twice a day or 3 times a day because you're spreading it out. But how do you find it? How do you consume it? Can you give us a little more information about that?
Yeah, I mean, generally, since it's still in the underground, it's word of mouth. And so where most, like, for example, my patients, since it is now in the city of Seattle, it's decriminalized, so they're not going to get in trouble, but a lot of my patients aren't in the city of Seattle. And even so, it's still underground. You have to find somebody. Generally, they're pretty easy to cultivate. It's pretty easy to grow mushrooms. So if somebody's really motivated, they could grow their own. Of course, there's risk, but like you said, if we're just talking about specifically therapeutic response and not legality, then that's a possibility, but it's, not, there's going to be a learning curve. So, or somebody that and trust, that's really where it is still to this day, for the most part, it's word of mouth and trusted sources, or you grow your own, really. Otherwise, I wouldn't recommend, I personally do not recommend just ordering it off the internet. You don't know where it's coming from, what it is, like that's dicey in my professional opinion. I don't endorse that. But yeah, really it's word of mouth. Now, as far as like how to administer it, generally it's capsules. It's just capsules, little, 00 caps, because that's 0.2 to 0.5 will fit in there. The other thing that I always recommend with microdosing is to also take 3 grams of lion's mane mushrooms and either 300 or 500 milligrams of something called nicotinic or nicotinamide riboside, which is basically a bioactive form of vitamin B3. And so those are just to support those neurological pathways, the BDNF with the lion's mane, and then the serotonergic system and dopamine, all the catecholamines, epinephrine, norepinephrine, et cetera. But with the B3, or some people say niacin. I don't normally recommend niacin because there's side effects, but something like NAD, NR, something. And just 1 cap of that. And I think that makes a really beautiful synergy and kind of helps balance out the effects of the psilocybin. I know you can do a tincture. You don't really have to. It's water soluble. Psilocin and psilocybin are water soluble, so people can make a tea, and or have some sort of aqueous extract. I'm looking into making an intranasal spray actually at some point of psilocybin for depression, because you can just do it as a tea basically, or saline. But for the most part, I would say it's capsules, and normally it's just 1 cap per day. Again, either 4 days on, 3 days off, or alternating days is most common as far as protocols. And then as far as the strengths of different strains or of mushrooms, basically different species, it's going to be just like cannabis in that it's highly variable, very widely, a wide range. But at this point, still, you got to look up the psilocybin and psilocin content of different mushrooms, because how potent they are is going to, again, potent, how strong, it's going to be based on the psilocin and psilocybin content together. So you can find that stuff online. Just look up different species online and what are the content. But you also have to realize, again, like with all natural medicines, how something is grown, where it's grown, if it's wild harvested versus cultivated, the potency is going to be different. It's not going to be 100% the same every single time, unless, I guess, if somebody were to grow their own and control the environment completely in a lab, they can control for a lot of those factors. But things like soil, light, all of those are going to affect it. So you technically have to test each batch to know, but different species tend to have higher content, and also a different experience, totally different experience. Less so, although still with microdosing, but definitely with larger doses. Like cyanescens, psilocybe cyanescens can be a little bit darker. It can be very therapeutic, but it can be a little bit more of a trickster than something like golden teacher. Even just the name says it. Yeah, but it's going to be person dependent, just like with everything. Some people love certain cannabis cultivars, and that will give the same person a panic attack, so you just kind of have to find your way, and it's not easy. These are all reasons to decriminalize or legalize this, because then it's so much better controlled, regulated, reliable than when it has to be black market.
It's almost like psilocybin is walking right behind the footsteps of cannabis. 8-9 years ago, I remember giving my mom these Jolly Ranchers, and I come home one day and she's laid out on the kitchen floor, and that's sort of like, oh, this is stupid. You gotta fix this. You gotta dose it. That sort of thing. So I'm assuming mushrooms are going to get there soon, and extractions and percentages and measurements and so forth, which I think is going to be exactly what needs to happen for us to be able to understand it. Just like the amount of information we get for cannabis right now, we were talking about, oh, I want to add CBN and CBG and for our patients, and we have so much information. There's almost none about psilocybin, and I think it's really really great that you have so much information to give us. So thank you very much. And we have I can't believe 55 minutes have passed by, and I want to reserve the right, Dr. Giles, to bring you back on again, because I'm not done at all, not even close.
Okay, great. I'll be here. It sounds great.
So please, Bob, we just have a few more minutes, and I wanted to ask about before we get off of this psilocybin, I want our listeners to know, and myself to know, is there a time that you know what the perfect dose for you is? I mean, is it 0.2 milligrams? Is it 0.4? Is it 1 milligram? And where do you know where where you need to be, and it's not going overboard? Because I'm sure there's some feel good, as you call it, the feel good effect of the medicine. People want to increase that, and in pain management, we have patients coming on asking for more and more and more opiates,
Yeah.
And we're trying to get away from opiates. But where's the right balance? How do you know where you got to be in this microdosing, and you titrate up, and then you got to level out? And when do you know when you got to level out?
It's a great question, and unfortunately, at this point, when I have these conversations with patients, it's still a little bit like you kind of can't know what your therapeutic dose is until you go too far, which can be uncomfortable. So there's probably going to be at least one day of some mild discomfort if somebody's totally psychedelic naive. They have no experience in psychedelics, and then I would say I would always start really low, so 0.1. And then the next day try or whenever on the schedule, their next microdosing day, try 0.2, and then maybe 0.3. And how you know you had too much is it's normally just a little bit, again, it's difficult to explain if somebody's never had a psychedelic experience, but you just kind of feel like you're tripping a little bit, and it's not super comfortable because you're not, but it's kind of like things just seem a little weird and sort of depersonalized maybe, or a little bit uncomfortable. Also, there can be GI effects, so it can be kind of cause some nausea, gastric upset. So it's best taken with food. That's going to obviously change things with food versus empty stomach. It's really best before meals, like shortly, maybe 10 minutes before eating breakfast. But just to kind of wash through some of that discomfort. But too much can cause more of that, more nausea, maybe some diarrhea, and maybe just feeling a little bit weird. And so, I tell people you just kind of got to ride it out for knowing that it's totally fine, it's totally safe, you're good, like it's fine. And do it on a day, obviously, that somebody doesn't have to like go to work or parent heavily or whatever. And then they know, okay, I hit the spot, and you pull it back. But only going in 0.1 increments again. So, and I don't think I've ever seen anybody need more than 0.5. Like 0.5 should be the max. So if somebody gets to 0.5 and they feel like they're having a good effect, I would not suggest going higher unless outside of maybe somebody's developed a high tolerance. But at that point, if they're seasoned, then they can kind of make that decision. But as you said, I think it's really important to remember that more is not always better in this case. It really isn't. You got to find that sweet spot, and it might change, and then a batch might be different, or you might get a different species, and it could be, that's like we're saying, I would really prefer it to just be able to be regulated, so you know what you're getting each time, because then it's very steady.
All right. All my lectures, I want to be on time, because that's a commitment of time. We have to start at the right time and stop. So we have 1 minute. I want to ask one last question. By the way, we're getting great comments. People love you. You're just a world of information. So if you don't have the time to thank you, I want to thank you that you've been on our show, and it's amazing. I'm just baffled by the amount of information that you have, and I'm very, very respectful for in our role, people call doctors. Medical school residency, cut people open kind of thing. I look at shamans as doctors, and I look at those guys that are ancestors. So thank you for being a shaman, and thank you for being an educator and getting on here. I will for sure get back with you. It's 7 o'clock, so I have another 30 seconds.
So
addiction profile of mushrooms.
the addiction profile?
Yeah, is there any addiction to mushrooms or not?
Not that I've ever seen. I honestly, I always say anybody can get addicted to anything, like idiosyncratically, just each individual person can. But there really are pretty strong anti-addictive effects. The mushrooms will kind of force a person not to abuse them to a certain extent. Again, ketamine less so, but mushrooms. The only time I've really actually seen it personally is with people who are on the schizophrenia spectrum, and they're kind of overdoing that side. But especially in low doses, not really a concern.
Julianna Giles,
Yes.
my hero, at least for the next few weeks, if not more. Thank you for being on. Thank you so much. Thank you for all the people that showed up to hear and listen. I hope we answered some of your questions. Please go on our website at sanctuaryme.com, so you'll be able to follow us on our other events. Again, thank you, Dr. Giles, and everybody have a good evening. Thank you.
Thanks so much.